silent epidemic in diabetes. Dr. Vipul Chavda is a very enthusiastic diabetes care physician from Ahmedabad, and he is a kind of diabetes leader in diabetes education and awareness around our Gujarat. He is a national and regional faculty for various education programs and for healthcare providers, principal investigators in many
Thank you,
trials, author, and has got many awards, as you can see here. I invite him to deliver his talk. Thank you.
Thank you so much, Chintan sir, for kind introduction. Let's talk about non-proteinuric kidney disease, a silent epidemic in diabetes. We all know that kidney disease are very important spectrum of complication of type 2 diabetes. And most of the time we evaluate the proteinuria because microalbuminuria is independent marker of CKD, even patient is diabetes or not. So most of the time in management of diabetes, in evaluation of the complication of diabetes, we mainly focus on proteinuria. But as we all know that every Shah is not Gujarati and every Shah is not Amit Shah, like Dr. Kiran Shah is from Maharashtra. So every proteinuric disease need not to be diabetes, and every kidney disease that is non-proteinuric is not a mild disease. So let's talk about it. But before that, I would like to invite you all and congratulate all to attending this wonderful World Congress of Diabetes at a Forum Convention Center, Ahmedabad. It's my own city and I welcome you all as a part of organizing team. And let's discuss a diabetic kidney disease, a very important part of management of type 2 diabetes. So what is non-proteinuric kidney disease? It refers to kidney disease where there is more decline in eGFR and the proteinuria is mild or minimum. Historically, we can see that diabetic kidney disease was considered as a part of proteinuric kidney disease only, and now it is a time that we have to understand, we have to evaluate that non-proteinuric kidney disease are very important part of DKD, and we have to screen them, we have to diagnose them, and we have to treat them to prevent many further complications. Talking about epidemiology, NPKD, the prevalence is between 20 to 40%. It is more common in person with have a longer duration of diabetes, person with having older age, women's are more prone to develop non-proteinuric kidney disease, and person with diabetes also prone to develop non-proteinuric kidney disease more. Talking about pathophysiology, there is a mild difference. When we see there is a glomerulus affection, there is a defect in glomerulus, there is leaking of protein that leads to proteinuria or albuminuria, but here the mechanism is slightly different. Here the main injury is microvascular, main injury is the tubulointerstitial damage. So key mechanism I would say microvascular ischemia, inflammation, fibrosis, and there is also endothelial dysfunction that leads to non-proteinuric kidney disease. So clinical presentation, as we started the talk by saying that it is a silent epidemic. So it is asymptomatic disease in very early stage. There is no leak of protein, there is no hypoproteinemia. That's why there is no edema in the patient and often identified as a routine EGFR testing. Okay, sometimes we see patient that came after 2 to 4 years and then the no reports has been done, or some peripheral area where the doctor or clinician is doing only fasting PP for years, and then once we do creatinine it finds out 2 or 3 and EGFR less than 50. So it is often identified when there is a routine EGFR testing is done, and now we are at a stage when we are having imaging, also some biomarkers as Dr. Kiran already mentioned, that can identify or help us to identify this non-proteinuric kidney disease in a very early stage. But there is some diagnostic challenges, as I already say that proteinuria is most of the time being tested. There is a spot albuminuria test available and most of the clinician evaluate kidney disease on the basis of this proteinuria. But again, proteinuria and creatinine measurement or EGFR measurement both are very important for the management or evaluation of kidney disease. So what are the risk factors for kidney disease? First and most important is longer duration of diabetes. More the duration, more the risk of developing kidney disease. Older age, geriatric population. We Indians are now the youngest population in the world, but after a decade or two, we will be the eldest population of the world. And being a high risk of cardiovascular disease, high risk of obesity and diabetes, we will have high risk for kidney disease. Talking about hypertension, the most of the people in hypertension are either non-diagnosed, or those who are diagnosed, 50% are taking therapy for that, and in that 50% who are taking therapy, less than 50% has a achieved the target blood pressure for them, and those who have achieved the target blood pressure, they are not taken care in terms of holistic care. They have BP under control, but their lipids are uncontrolled, their sugars are uncontrolled, their obesity is unchecked, and that's why they are at high risk of many other diseases like kidney disease, microvascular injury in diabetes, poor glycemic control. We all know about legacy effect. When we deal diabetic patient, we have to take a power play in first 5 years. If we keep HbA1c below 7 in first 5 years of the journey of diabetic individual, we can prevent many complications including proteinuric as well as non-proteinuric kidney disease, metabolic syndrome. We always see a hypertensive patient as a hypertensive patient. We focus on glucose in diabetic population, but now it's a time that we have to see patient in total. We have to see any diabetic patient, any patient with fatty liver, any patient with hypertension to be a part of a spectrum of metabolic syndrome, and we have to evaluate and we have to treat a person is a as a metabolic syndrome disease, not only just diabetic or hypertensive or dyslipidemic. And there are some challenges in evaluation of this disease because it is asymptomatic, so most of the time it is overlooked, and there are some limitation of laboratory testing in peripheral part of India. That's why it is over often missed. So what is the management for non-proteinuric kidney disease? Again, the non-proteinuric kidney disease and proteinuric kidney disease, the management is almost same. First and most important is good glycemic control. We have to keep HbA1c less than 7. Again, the number may be individualized along associated with the comorbidities or complication in the patient. The blood pressure target is less than 130/80 in diabetic population. And talking about pharmacotherapy, most of the patients are on RAS or ACE inhibitor, but now SGLT2 inhibitor and GLP-1RA are very important part of management. Most of the time when we are dealing with kidney disease, we focus on albuminuria and we start ACE inhibitor, ARB, and now we also have finrenone. But we have to consider that preventing fall in EGFR is also very important, and at that time GLP-1 and SGLT2 inhibitor are very important part of the therapy. Prognosis and complication, of course the non-proteinuric has a very slow progression, but the risk is same, so we have to consider is a equally important part of the disease, and we have to consider the therapy as a part of the whole management of diabetes. Current guidelines and recommendation ADA KDIGO both says not only proteinuria measurement, UACR measurement is important, but EGFR measurement is also important in all the patients with type 2 diabetes, and comprehensive risk factor management like ABC, HbA1c, blood pressure and cholesterol, all three has to be managed. So let's take a case who is a 55-year-old female with type 2 diabetes since last 10 years. Her EGFR is 55 but normal UACR. So here the 55 EGFR indicates a significant injury to the kidney. There may be no injury to the glomerular, so there may be no proteinuria, but there may be injury to a tubulointerstitial tissue that can lead to fall in EGFR. And we have to manage this patient as a holistic care, in a holistic care approach. SGLT2 inhibitor, GLP-1RA may be the part of therapy, and BP and sugar and lipid managements are also very important. So what are future direction and research gaps? We need to have a better biomarker to early screen the patient with non-proteinuric kidney disease. We have to continue GLP-1RA and SGLT2 inhibitor for better prognosis in this non-proteinuric patient, and we also require some longitudinal study for evaluation of novel therapies for this NP kidney disease. So I would conclude by saying that the NPKD is a silent epidemic. It is underdiagnosed and more prevalent in diabetic population. EGFR should be measured and also proteinuria should be measured. One of the measurement will not give us a complete picture. Both of them should be measured, and multidisciplinary approach and management improves the outcome in diabetic population. So in the end, I will say it is a time of collaboration. A diabetologist, nephrologist, cardiologist, we have to work in association of each other, and collaborative work enhance creativity as well as innovation. Together we can achieve the greater goals. Thank you so much for your support, and thank you so much for your listening.